بسم الله الرحمن الرحيم. Many thanks, Dr. Walid, for asking me to co-host this meeting with you. And it is my pleasure to present Dr. Ahmed Higazi. Dr. Ahmed Higazi is a senior critical care physician and cardiac anesthetist. He's currently working at King Faisal Specialist Hospital, and he is in charge of the cardiac ICU at King Faisal. And he have been working previously in and still working in Canada. So I would say he have one limb here, one limb there. And Dr. Ahmed, as I know, he's studying to get a degree in Islamic studies. So I'm sure with this topic of this event with end of life between religion and medicine, I'm sure he will give us a new sides, and he will shed light on a lot of areas which can cause controversy. Especially, he have worked in Western country, and he is currently working in Saudi Arabia, armed with his knowledge in critical care, anesthesia, and as formally studying Islamic studies. Dr. Ahmed Higazi, you are most welcome to start your presentation.
Thank you so much, Dr. Hisham. Jazakumullah khair. Bismillah. I appreciate the invitation, and this is a topic that is extremely important, and it touches all of us who work in critical care, where we deal with life and death on a daily basis. And so the title of my talk is End of Life Between Religion and Medicine. And the way I'm going to tackle this topic is that I'm first going to talk about the ruling in Islam about seeking treatment and cure. Then I will talk about the ruling of stopping life support. And after that, I will talk about the rulings on setting limits on medical interventions. But I will tackle these topics both from a medical standpoint and from a religious Islamic standpoint. And then I'll talk about preparation for death and what is our role in that time. And then I will talk about the definition of death itself between religion and medicine. So I'll introduce the topic by saying that I will reference everything I say from a religious and from a medicine standpoint. I will put forth the references, and this is not only part of the culture of medicine, where we say referencing gives credit, supports claims, it enables verifying the information and replicating the information, and facilitates future research, but it is part of our religion as well as Muslims. In fact, one of the great scholars, Abdullah ibn Mubarak, said, إن الإسناد من الدين ولولا الإسناد لقال من شاء ما شاء. Referencing is an integral, essential part of our religion. And if it were not for referencing, anybody could say whatever they want. And so I will reference everything I say, both from a medical and a religious standpoint. When it comes to religion, I will try to stick with the four major sources of Islamic legislation, Masadir al-Tashri'a. And these are obviously, as we all know, the Quran and the Sunnah primarily. And then the consensus of the scholars. And then drawing parallels, al-Qiyas, al-Ijma' wal-Qiyas. Al-Qiyas, drawing parallels, is when we don't have an exact we have a situation right now which was not exactly present at the time of the Prophet ﷺ, but a similar situation was present, and we can draw parallels. We can make qiyas between both situations and draw rulings accordingly. And then in terms of my references from a medical standpoint, I'll obviously reference the legitimate sources like systematic reviews, randomized controlled trials, cohort studies, and so forth. from a religious standpoint, there is a small handbook that is actually quite well written, and it tackles the topic of Islamic jurisprudence from a medical standpoint, or medical jurisprudence, al-fiqh al-tibbi. And this is a nice publication that I actually have a soft copy of and have referenced in parts of this presentation. So let's start and go ahead and talk about seeking treatment and cure. And this is fundamental to our talk today. We need to understand, what does our religion say about seeking treatment and cure, and what are the methods of seeking treatment and cure? And so from a medicine standpoint, we all know that seeking treatment can be either through medicines or procedures, like surgeries, but it also could be through prayer. And I list that under the column of medicine because actually the topic of prayer has been studied in a medical context and published in journals. And I will go through that shortly. From a religious standpoint, we all know that first and foremost, whenever we are struck with a disease, with an ailment, with a hardship, with a test from Allah subhanahu wa ta'ala, that the first thing we turn to is Allah subhanahu wa ta'ala for cure. We don't really, with our hearts, turn to the physical means. Our hearts actually turn to the creator of these physical means, because he is the one that owns and holds the cure for you. The physical means are just physical means. And so you can seek cure through prayer, making dua, and if you make a specific dua or specific prayer with the intention of seeking cure, we call that, from an Islamic standpoint, ruqya. And you can also seek treatment through the physical means, the modern medicinal means and procedural means. And certain procedural means have been listed in the Sunnah specifically, include things like hijama, honey, cautery. And you can seek modern medicinal means, and this has been actually encouraged in the hadith. And we'll go through that as well shortly. But let me go back to prayer and how it fits in medicine. And this has actually been studied, and most people are not aware of this, but there have been a few studies, and I'm just going through one of them, but there's actually quite a few studies that have looked at the effect of prayer on outcomes from a medical standpoint. This is a randomized controlled trial of the effects of remote intercessory prayer on the outcomes in patients admitted to the CCU. And this is actually an RCT. It was published in 1999, and since that time there have been quite a few studies that have been published as well, some of them in the ICU. But in this study, they looked at 990 patients admitted to CCU, and patients were randomized to one of two arms. One arm got remote intercessory prayer daily for 4 weeks, and the other arm got usual care, which means no prayer. And basically, the way they designed this is that the patient admitted to the CCU was randomized to one of the two arms. If he got randomized to the arm of prayer, they gave his name or her name to the person assigned to make prayer for them. And the person assigned to make prayer was at a remote location, and the patient did not really know that he was being prayed for. So it was truly a blinded RCT. And the patient making the prayer himself or herself was not actually connected to that patient. Like they weren't related to them, they didn't know them personally. And so patients were randomized to either getting prayed for every day for 4 weeks versus usual care. And the outcome was CCU course score and CCU length of stay. What is the CCU course score? I will go through that shortly. The CCU score is basically a scoring system that indicates the severity of the illness and the interventions required to treat that illness. You can see here, when you start off with a CCU score of 1, you're just basically coming in for anti-anginal agents. You're on monitors, but you're really not that unstable. When you start getting into arrhythmias and requiring inotropes, then you're going into a CCU score of 2. When you start requiring more invasive interventions like a temporary pacemaker, Swan-Ganz, ICD, then you're going into a CCU score of 3. When you start needing interventions that are more invasive, like intubation, ventilation, permanent pacemaker, intra-aortic balloon pump, a PCI, then you're a CCU score of 4. If you sustain a cardiac arrest, then it's a 5, and if you die, then it's a 6. So you can see here that the CCU score, the higher the CCU score, the worse the outcome. And what they found was, in patients that had remote intercessory prayer had a lower mean CCU score compared to the usual care group. And you can see here that the CCU score was actually lower in patients who had prayer into remote intercessory, 6.3 versus 7.1. The length of CCU stay and the hospital length of stay was no different. But you can see here that there was a positive study in terms of the severity of illness. It seemed to be much less in patients with who received remote intercessory prayer. And so, what is the ruling though well, or what are the means, or I guess what are the rulings that we should really stick with when it comes to providing medical treatment? First, when we provide medical treatment to a patient in the ICU, it's important from a medical standpoint and from an Islamic religious standpoint to respect the patient autonomy. Do not force any treatment on a patient when they are not consenting to it. So patient autonomy is number one. What they want takes priority. And then number two, you want to act on the patient's best interest, or actually patient's values and pre-expressed wishes. So if a patient is unable to speak for themselves and they're on a ventilator in the ICU and they have pre-expressed wishes and values, then we should definitely stick with these values. If the patient does not have pre-expressed values and wishes, then we are expected as physicians to act in the patient's best interest. From a religious standpoint, providing treatment falls between different categories. It can be, in certain situations, strongly recommended or preferable, and in some situations, it can be permissible. And I will go through these in detail right here, right now. And so what I'll say is the scholars have broken it down into different categories. Seeking treatment is strongly recommended if the disease is curable and it is life or limb threatening. So something that is curable, modern medicinal means can cure, and it is life or limb threatening, then it is strongly recommended, highly recommended that you seek treatment. And the majority opinion here is that it's not obligatory, but it's very strongly recommended. And it can become preferable if the disease may lead to disability. And it can be permissible if it's neither of the above. It won't lead to disability and it's not life or limb threatening, then it's permissible, obviously, to seek treatment. And it can be not allowed if the complications of treatment are more severe than the primary disease itself. This last category is more theoretical. We don't usually offer treatments that have severe complications that are worse than the disease itself in medicine. And so why do we say it, why do we say it's permissible, and why don't we say, so let's go through this hadith here. And this hadith, prophetic tradition, is quoted very often by families. Everybody knows it, everybody memorizes it. When the Bedouins came to the Prophet ﷺ, they asked him, shall we treat our ill? Shall we seek cure, seek treatment? And the Prophet ﷺ said, نعم يا عباد الله تداووا فإن الله لم يضع داء إلا وضع له شفاء. Yes, O worshippers of Allah, seek treatment, use remedies, for indeed Allah did not create a disease except that He created a cure for it, except for one disease. And so the companions asked, O Messenger of Allah, what is that one disease? And he said, Al-Haram, meaning old age and senility. There is a cure for all the diseases that Allah has created except for senility, Al-Haram, old age. And so we say here that the Prophet ﷺ is actually ordering us to seek treatment. And why are we saying that it's strongly recommended, but it's not obligatory? It's because of another hadith. And this is a very famous hadith that all of us actually have probably heard about, that Ibn Abbas radiallahu anh, one of the companions of the Prophet sallallahu alaihi wasallam, was with one of his students and told him, do you want to see a woman of Jannah? And then the student said, yes, I'd like to see her. And so Ibn Abbas radiallahu anh pointed to a woman and said, this woman here, this black woman, came to the Prophet sallallahu alaihi wasallam and said, I suffer from epilepsy, and during my fits, my body is exposed. So make supplication to Allah for me, O Prophet of Allah. She asked the Prophet ﷺ to make dua for her so that Allah cures her from her epilepsy, from her seizures. And so the Prophet ﷺ gave her a choice, one of two options. He said, if you wish to endure it with patience, then you will be rewarded Jannah. But if you wish that I make dua for you for Allah subhanahu wa ta'ala, that Allah cures you, then I can definitely do that. And so now she's given a choice between one of two things: a guarantee of Jannah if she has patience on her disease, or that the Prophet ﷺ makes dua for her and Allah subhanahu wa ta'ala will cure her. And we as Muslims all know that if the Prophet ﷺ were to make dua for her to cure her, Allah subhanahu wa ta'ala will respond to that dua from his Prophet and will cure her. So this is 100% guarantee for cure. And on the other side, there's 100% guarantee of Jannah if you have patience on your disease. And so she, when faced with that choice, said, okay, if Jannah is what I get if I am patient, then I shall endure, I shall have patience. But then she said, my body is exposed, and so pray for me that it does not happen, so that my body is not exposed. And the Prophet ﷺ made dua for her that this does not happen. And so when she got seizures from this point onwards, it was always in her home where she would not be exposed when she would get these fits. And so what do we learn from this hadith that we've all memorized and we all know? But Ibn Taymiyyah, Ibn Hajar, the great scholars of Islam, said in this hadith there is permissibility not to seek complete cure, because the Prophet ﷺ told her that you have one of two options, either complete cure or patience, and she chose patience. And so in this hadith we actually draw, and the great scholars of Islam all said that in it is a ruling that is embedded for us, that seeking complete cure is not obligatory, or else the Prophet ﷺ would have made dua for her. It's not obligatory. It is permissible, but and sometimes even preferred, but not obligatory. And this is a very clear evidence of that. And that's why a majority of the scholars say seeking treatments is either preferable or permissible. Abu Hanifa, Malik, most of the Shafi'is, most of the Hanbalis, Ibn Taymiyyah, Ibn Hajar, Ibn Abdul Barr, all of these scholars all said that seeking treatment is either preferable or permissible. And a minority of scholars said that it is wajib, that is obligatory. And these are some of the Hanbalis and some of the Shafi'is. But I quote the authentic sources here, where Ibn Taymiyyah said, أما التداوي فليس بواجب عند جماهير الأئمة وإنما أوجبه طائفة قليلة. So seeking treatment is not obligatory amongst the majority of scholars, but some of the scholars made it obligatory. But we have the evidence here from the Sunnah of the Prophet ﷺ that it is actually not obligatory, but it can be preferable or even strongly recommended in certain situations. So this brings us to the question, okay, so does seeking cure change your fate? This is a question that was asked by one of the companions of the Prophet ﷺ. He said, I asked the Prophet ﷺ, أرأيت رقا نسترقيها ودواء نتداوى به وتقاتا نتقيها هل ترد من قدر الله شيء? All these means of seeking cure, the dua that we make, the ruqa that we make, the things that we try to avoid, does it change anything from Allah's decree? And the Prophet ﷺ said, these means that you are taking, they are from Allah's decree. قال هي من قدر الله. And so they are from the qadr of Allah, Allah's decree. Let's move on to the next topic, and that is stopping life support. What is the Islamic ruling on stopping life support? And so in this, we turn to a consensus statement. I will come to this consensus statement shortly, but let me first explain a bit of a background to this issue. When it comes to stopping life support, a lot of patients are actually critically ill in the ICU, on ventilators, unable to make decisions for themselves. And so we turn in the Western world and in most of the world, we turn to their substitute decision makers. And what a substitute decision maker means is that that's a designated person who is authorized to make decisions on behalf of a patient who is unable to make important decisions about their own personal care. There's another term that is used here in Canada as well, and that is a power of attorney. A power of attorney means that a person has a legal document that says that I am appointed to make personal care decisions on behalf of this patient. And so the difference between a substitute decision maker and a power of attorney is that a power of attorney definitely just has a document, a legal document that says I am authorized to make these decisions. This is something you do with a lawyer before, while you're well and not ill. Substitute decision maker, we default to the substitute decision maker or the SDM. If the patient does not have a legal document, we go to the SDM. They don't need to have a legal document. If there's no legal document, then we just have a hierarchy to go for whoever is in this ladder. So in Ontario, we have a hierarchy of who we should go to make decisions. If there is obviously a document for personal care, an attorney, personal power of attorney, then that trumps everything. We go to the person who has the document. But if there's no document, then we turn to the spouse or the partner. And that's why I always say, be careful who you marry. They may be making decisions on your behalf one day. And so you turn to the spouse or the partner. Here in Ontario, that's the law. And if not, if there's no spouse, there's no partner, then you go to the parents or the children. And if you can't find any, then you go to the siblings. If you can't find any, that any other relative. And if you cannot find any, and we do get patients sometimes who have no relatives, nobody to really make decisions on their behalf, in which case the government appoints a public guardian and trustee. And that is an SDM of last resort, a substitute decision maker of last resort. So let's go back to what I was mentioning, stopping life support. How should we as Muslims deal with this issue? What is the ruling from our religious standpoint about stopping life support? And I put my references down here. And the ruling that is now fully established is based on two conferences actually that took place. The first conference took place in 1987, and that conference was in Jordan, and it was a huge conference of scholars. It was basically a huge body of scholars, all scholars of Islamic fiqh and jurisprudence, Majma' al-Fiqh al-Islami. And in this conference, they invited physicians. And so physicians were invited and videos were shown, and basically so that the scholars of Islam understand exactly what we're talking about, exactly how modern medicine works. This conference actually was a joint conference where physicians were involved to explain what current medicine looks like, so that when a consensus opinion is formed by this conference, it is based on the evidence and based on the most recent practice. And so what they came up with in this conference, and this is a very clear statement here, they say if resuscitating the heart and lungs is futile and not suitable for a certain condition, as per the opinion of 3 expert, trustworthy physicians. So we need a consensus of 3 physicians that resuscitation of the heart and lungs is futile, and there is no need in that case for the use of resuscitation machines, and there is no need to turn, and I mean, I want you to pay attention to this statement. It's actually a very strong statement. They say there's no need to turn to the opinion of the patient's family in this regard, as this is a matter that is not within their area of specialty. And so this is a consensus statement. As we mentioned, consensus is one of our sources of legislations. We mentioned the Quran, Sunnah, consensus, and drawing parallels. And so in Canada, we have a protocol for withdrawing life support. We call it the Withdrawal of Life Support Protocol, WOLST. And when you write withdrawal in the order set and the computer, an order set will come out that will say crit care withdrawal of life support, WOLST. And that order set actually focuses on making patients comfortable. your goal here is that you don't see any signs of grimacing, agitation, pain, or respiratory distress. And so that is your ultimate goal in patients who are undergoing withdrawal of life support. And you can use things like hydromorphone in this situation with the intention of making patients comfortable. That's your intention here, is just to remove pain so that the patient does not look like they are in pain. And you can also use midazolam, boluses, and infusion. Obviously, there's no need to start doing blood work and poking patients who are undergoing withdrawal of life support, because this will just add to the discomfort. In our protocol, we said once the patient looks comfortable, there's actually an order set. The patient may be extubated at that situation once they're comfortable and breathing spontaneously. And so this is the withdrawal of life support order. And I always mention this when I'm rounding with my residents in Canada. I always say, a lot of times they'll say because the family said he would not accept this quality of life, then we are going to withdraw care. I always stop them right there and say, we're not withdrawing care, because we always care. It's called withdrawal of life support. It's not called withdrawal of care. We care for patients, even patients who are dying. We definitely care for them. And so withdrawal of life-sustaining therapy or withdrawal of life support is what it's called. It's not called withdrawal of care. So let's move on to the next point here. So what about setting limits on medical interventions, DNAR? What is the ruling on setting limits on medical interventions, or DNAR order? I will turn again, and I reference here Lajna Da'ima under the leadership of Sheikh Abdulaziz ibn Baz. And this fatwa was based also on another conference that took place a year later, also in the 1989, I believe. And that took place in Mecca. And so you have two major Islamic conferences here that were similar in nature. And that conference in Mecca was basically also focused on looking at interventions related to medical practices. And what they said in terms of orders for do not attempt resuscitation in this consensus statement is that if the patient's sickness is chronic and untreatable, and death is inevitable according to the testimony of 3 trustworthy specialist doctors, in which case there is no need, in these cases, there is no need to use resuscitation equipment. You can put limits. You can say, do not attempt resuscitation in these situations, but you need the consensus of 3 trustworthy expert physicians. And so if you have 3 expert physicians who are all in consensus that the condition is chronic and untreatable, then you can put limits, do not attempt resuscitation limits. And if the patient is also, they go on, and there's 6 points in that consensus statements. And the second point they mentioned, if the patient is incapacitated or is in a persistent vegetative state or chronically ill, or in the case of cancer in its advanced stages, or chronic heart and lung disease that's not treatable, or with repeated cardiac arrests, with repeated cardiac arrest, then 3 trustworthy specialist doctors have determined that there is no need to use resuscitation equipment, then it is permissible to also order a do not attempt resuscitation order. And then they go on to say if there is also any indication that the patient will have brain injury that cannot be treated according to the reports of 3 trustworthy expert physicians, then there's also no need to use resuscitation equipment, because there's no point in doing so. And this is a consensus statement by our scholars. And then they say reviving the heart and lungs is of no benefit. And so all of these have similar meanings, and is not appropriate because of the certain situation, according to the opinion also of 3 trustworthy expert specialist physicians. Then there is no need to use resuscitation equipment. And they mention that you don't need to actually turn to the opinion of the family in this situation, because it's not their area of specialty. Obviously, I definitely tell families about this. I definitely talk to them about it. But ultimately, in the end, according to the statement, it really is a medical decision. And it has to be 3 expert physicians who are in consensus about the status of the patient. And I just put it up here in Arabic for those who want to reference the actual statement itself that was published and the 6 points of that statement. It's all listed here in Arabic. I went through it in English, but it is all here as well. Whoever wants to refer to it, it is publicly available. This fatwa or this consensus statement by our scholars, rahimahumullah. And so here, we have an order set, obviously, in Canada that says do not resuscitate. It's called the resuscitation status care set, and that, or do not attempt resuscitation. And that is actually done for every single patient admitted to hospital. It's mandatory. If a patient is admitted to hospital and nobody's completed the resuscitation status care set, it will show up as soon as you open the patient chart to remind you. You should complete the resuscitation status care set because this patient is now admitted to hospital and nobody's completed it. And so it needs to be completed. Obviously, the default is full resuscitation. That's the default, right? But if there are pre-expressed wishes or orders that we have, then we definitely need to turn to those. Obviously, you need to document how, why, or who, what you base that decision on. Is it the patient? Is it the relative, the substitute decision maker, their spouse, their parent, their son? Or is it a document that have pre-expressed wishes? Some patients actually come with documents that have actually documented that they are not for full resuscitation. And so you need to document that, and it's mandatory for all patients admitted to hospital. And in Canada, we divide it into 4 categories. There's full resuscitation is obviously a separate category, but when it comes to DNAR is 4 categories. There's DNAR advanced with advanced resuscitation, basic, restricted, and comfort. And the way it's divided here, at least in the hospital that I work in Canada, is that when it's patient is DNAR advanced, it means that they are already ventilated, they're already on inotropes, they're already in the ICU, but you're just putting limits on chest compressions and defibrillation. So if the patient arrests, despite maximal medical therapy, despite being on a ventilator, despite being on inotropes, then you're just drawing a line there that they're saying if the patient arrests despite all this, then we're not going to do the chest compressions or the defibrillation. This is what we call DNAR advanced. DNAR basic means that the patient is not for intubation. So that is somebody who comes to the ICU who says, please, no intubation for me. So no intubation, no chest compression, no defibrillation. DNAR restricted means that they are not for ICU admission. Basically, they're not for mechanical ventilation and they're not for vasoactive drugs. So pressors and mechanical ventilation, they're not a candidate for those, and this is what we call DNAR restricted. DNAR comfort means you just focus on comfort only. And that's all you focus on with your treatment. And so this also is a question that also comes up quite frequently with families. Families will come and say, no, doctor, we should not put limits on life support. This is like committing suicide. And so isn't putting limits in DNAR and withdrawing life support, isn't that similar to committing suicide? Isn't that the same? And actually, the scholars say it's absolutely not the same. It's absolutely, there's no similarity between both. And I'll show you why here. It's because when the Prophet ﷺ described what committing suicide is, he described it clearly in this hadith as the purposeful act of taking your life away through active means. And what do I mean by that? When the Prophet ﷺ said, whoever kills himself with an iron weapon will be carrying that weapon in his hand and stabbing his abdomen in hellfire, where he will abide eternally forever. Whoever intentionally drinks a poison to kill himself will be carrying his poison in his hand and drinking it in hellfire, where he will abide eternally. Whoever throws himself from a mountain and kills himself will be throwing himself, will be in hellfire, falling down from it and abiding therein perpetually forever. You can see here, there's an act of commission. There's an act that is active with the intention of taking your life away. And so committing suicide is an active process of taking your life away. You're doing something, taking a poison or throwing yourself or stabbing yourself with the intention of taking your life away. This is completely different. It has no similarity to just stopping what you're doing in terms of treatment and letting Allah subhanahu wa ta'ala yani determine. This has no similarity. There's no active act here. There's no real act here where you're committing an act with the intention of taking somebody's life away. This is completely different than committing suicide. And so, what about MAID or euthanasia? We've all heard about the euthanasia. Euthanasia in Arabic, qatl al-rahma, or MAID, which is medical assistance in dying. We've all heard about that, and this is very different. What MAID is actually giving medications to a patient upon their request with the intention of taking their life away. So here the intention is actually causing death. And so in a lot of countries, Canada included, in Switzerland, in some US states like California, Colorado, DC, Montana, Oregon, Vermont, and Washington, all of these states have laws where patients with a terminal incurable illness who are fully competent and neurologically intact have the right to request medical assistance in dying. They have the right to actually ask for their life to be ended. In these states, according to the law, they have that right. And in Canada as well, where I practice, patients do have that right as per the law. And how is it commonly performed? It's commonly performed by injecting large doses of midazolam, propofol, and rocuronium without supporting the airway. It's very, when you think about it, it's actually very easy. If you give somebody large doses of midaz, rock, and propofol, they'll and not support the airway. They will likely pass away very quickly. And so here, the intention of giving these medications is actually taking life away. What is the Islamic ruling on this? Completely forbidden, completely impermissible, regardless of who asks for it, whether it be the person, the patient, the family, anybody who asks for it. This is impermissible. Giving the medications with the intention of ending life is completely impermissible, regardless of who requests it. And that is the Islamic ruling on that from a jurisprudence standpoint. Let's move on to the next item here, and that is, how do we prepare for death? The moment is close. This patient is in his final moments. What rights do they have on us as healthcare providers and on their families as well? Prior to this moment, obviously, we were all encouraged in the prophetic hadith to have a will during our health. While we are alive and well this day and age, we should not go to bed at night before we actually have a will that describes what we will, what we call in Arabic al-wasiyya. Al-wasiyya is encouraged by the Prophet, definitely, that everybody should have a will before that moment comes while they're well and healthy. Family are obviously encouraged to remind the patient, and we're all encouraged to remind patients who are close to death of Allah's mercy. Now, we all know that our worship of Allah subhanahu wa ta'ala is based on three emotions. The first is hope in Allah's mercy. The second is fear of Allah's punishment. And the third is love of Allah subhanahu wa ta'ala. And we all worship Allah based on these three, but the scholars say when it comes close to your death, then تُغَلِّبُ جَانِبَ الرَّجَاءِ. You should always remind people who are close to death of Allah's mercy, of Allah's all-encompassing mercy. And so the testimony, the shahada, the last words should always be something that we should remind patients of if they're capable. Obviously, if they're not capable and if they're intubated or unconscious, then they will not be able to say the shahada. Obviously, once the patient passes away, it is important to actually close their eyes as part of the sunnah as well. So this article was published here in the New England Journal in 2014. It's called Dying with Dignity in the Intensive Care Unit. And I here go back to the medical side. This article was actually a well-written article where they talk about the ABCD of dying with dignity, or dignity conserving care. And they say that physicians should be aware of their attitudes and assumptions and how they affect their practices. Their behaviors should always enhance patient dignity. They should always treat patients and families with compassion and sensitivity and a desire to relieve the suffering. Dialogue should acknowledge the person that you are treating. It's not just a patient, but this is an actual person who has memories and families. And so you should always encourage that in your dialogue, is to explore who we are as a family. Now, you should reflect on how your life experiences as a physician may affect the way you provide care. You should be aware of yourself and try to be non-judgmental, and teach learners as well how to be mindful of their perspectives and presumptions and how they can shape your behavior. When it comes to behaviors that enhance dignity, it's important that when you discuss these issues of life and death, when you have an important discussion to make with families, is that you do not rush it. You sit down, you prepare a quiet room, you make eye contact with family members when talking to patients themselves if they're awake. You turn off digital devices, avoid jargon, avoid complicated words that they will not understand. Try to be simple when talking to patients and their families so that they can understand what you're saying. You try to have compassion. Ensure that you explore who that person is that you're treating and what they valued, what they wished for, and acknowledge that this is a sickness in the context of a broader life experience of that patient, and try to recognize that the patient, that any suffering or any pain will be treated, and we will try to make sure that the patient is comfortable during his final moments. I always ask, is there anybody he or she would like to see in these final moments? Is there anybody who's important who would actually like to see their loved one before they pass away? Dialogue should explore values that are very important to patients, and encourage patients and families to reflect on and reminisce on their memories. You should always express sincere condolences. You should always remind them, if you're treating a Muslim family, of Allah's all-encompassing mercy. Now, this is a spiritual history that is also encouraged in this article. I personally have not found it to be very useful. They talk about exploring spiritual belief systems, personal spirituality. I personally have not thought that this is something that I've adopted in my practice very much. However, it's important to honor your patient's spiritual beliefs. Whatever their cultural, spiritual, or religious beliefs are, it's important to honor them. If they're passing away and they'd require a priest at their bedside, you should definitely honor that and call spiritual care services or a minister, or if they're asking for somebody who they trust, their religion, a sheikh, for example, to make dua for them, then you should try as much as you can to make that happen. These are their final moments. These are memories that they will never forget about the passing away of their loved one and how the healthcare team treated their loved one in their final moments. Death brings us to the final station, the inevitable outcome, the outcome that we will all face at one point, sooner or later. The outcome that, unfortunately, we are very ill prepared for, unfortunately. Most people are not prepared for this final moment, and that's very, very unfortunate because we all know that this is where we will all, this will be our final abode. And so here, from a medical standpoint, death is defined as circulatory death or neurologic death or brain death. From a religious standpoint, the definition of death is when your spirit, your soul, leaves your body. Tarakat al-ruh al-jasad, and this is where death is defined from a religious standpoint. So let's talk about the medicine side first. From the medicine side, the neurologic determination of death needs 5 criteria, and these 5 criteria are considered the gold standard for diagnosing brain death. First, you have to have an established cause for why this patient is brain dead, a cause that is known to increase your intracranial pressure or a direct injury to the brainstem. So somebody, for example, had a severe traumatic brain injury, or somebody had an anoxic event like a post-cardiac arrest, an anoxic brain injury, and now their brain is swollen and their ICP is through the roof. And so you have to have an established cause like post-anoxic, post-traumatic brain injury that can lead to brain death. Confounders must be absent. And what I mean by confounders, it is factors that can mimic brain death. They should all be absent. You should rule out that there's any confounder that is present. The patient needs to be in deep, unresponsive coma. And what I mean by confounders here, before I move on, confounders are conditions that mimic brain death. The patient should not be under the effect of any sedation for the last 24 hours at least, at a minimum. So no sedation, no paralytics, no severe electrolytes derangements. They're not severely hypophosphatemic or severely hypernatremic. They're not hypothermic. That tends to be an extremely important one. They need to be normothermic when you diagnose brain death. And so confounders, or conditions that can mimic brain death, must be absent. And then the patient, as I said, must be in deep unresponsive coma. So there's the 3 C's: the cause, the confounders that are absent, and the coma. And then 2 other criteria, and that is they should have absent brainstem reflexes, and they should have an apnea test that is positive, meaning that they will never breathe on their own again. And so in Canada, the Ontario law mandates that the assessment is completed by 2 fully licensed physicians, cannot be trainees. They have to be actually licensed physicians, not trainees. And so obviously they need to be expert in that field as well. And so when we talk about brain death or neurological determination of death, these are the criteria that we have in our protocol in London Health Sciences Centre, where I practice ICU and anesthesia. So they need to have no response to nauseous stimulation above the clavicles, and no response, except for potentially the spinal reflexes, to nauseous stimulation in all extremities. The pupils should be mid-position and non-reactive. You have to have bilateral absent pupillary constriction to light, bilateral absence of corneal stimulation, bilateral absence of the cold caloric response. When we inject cold saline into the ear, trying to elicit a cold caloric reflex, or the oculovestibular reflex, we see no movement. And we typically will do that on both sides to make sure that there's an absent oculovestibular or cold caloric reflex, the absence of a gag response, and the absence of a cough response to tracheal stimulation as well. So when you put a suction catheter down the ET tube, they will not cough. If they cough, it means they're not brain dead. There's some activity of their brain. You cannot diagnose brain death if somebody has a cough reflex. And so I usually start with that cough reflex, actually, because it tends to be the last one to go away. And so sometimes I'll do the examination. I'll start with my corneals, the pupils, the cold calorics, the gag, and go to the cough and find that they're coughing. That means they're not brain dead. And so basically, I usually start with a cough because it's the last to go away. So if they're not coughing, definitely, then I can proceed with the rest of my examination. And I need to complete the full examination in order to diagnose brain death, including the apnea test. And the apnea test is basically, the idea of it is that you're giving a CO2 challenge to the patient. You're basically stopping. What we usually do is that we maintain oxygenation. There's 2 ways of doing it. The way we do it in Canada is that we set the ventilator to 100% FiO2 and set the respiratory rate anywhere from 2 to 4 breaths per minute. And we put the patient on end-tidal CO2. And so what you're trying to achieve here is obviously maintain oxygenation, but for CO2 to build up, you're hypoventilating intentionally so that their CO2 rises by more than 20 millimeters mercury above their baseline. CO2 is the most powerful stimulant of the respiratory center. And so if you start off, you draw a blood gas at baseline first, and then you change the ventilator settings. That's one way of doing it. The other way of doing it is putting a catheter down the ET tube and insufflating oxygen through the ET tube, and that way maintaining oxygenation. And so you draw a blood gas at baseline, and then you you basically start the apnea test, you reduce the rate on the ventilator, or you disconnect them from the ventilator and put an oxygen catheter down. And then you basically wait until the CO2 on the next blood gas is more than 20 millimeters mercury from baseline. And so when we do it in the pediatric ICU, for example, you have somebody doing blood gases every 10, 15 minutes or so. If we are doing it here at LHSC, we're usually connecting the patient to the ventilator and have end-tidal CO2, so that'll give us an idea when they've risen above 20 millimeters mercury from their baseline. So if they start off with an end-tidal CO2 of 40, we do the blood gas when their end-tidal CO2 is above 60, because that's 20 millimeters of a difference. And so their pH also has to have dropped to less than 7.28, and the PCO2 must be greater than 60 millimeters mercury. And so if, despite all this, they're not breathing, while we're doing the apnea test, we're monitoring the patient for any respiratory efforts. If they have any respiratory efforts, if they breathe at all, if there's any effort to breathe by the patient, then they're not brain dead. So the apnea test being positive means that there's absolutely zero respiratory efforts, despite the CO2 challenge and despite these testing. And so, as I said, clinical testing with all these tests is considered the gold standard in Canada, generally speaking. Ancillary testing is indicated only if clinical criteria are not met. If you cannot tick off all the boxes, then you need to proceed to ancillary testing in Canada. And so you need to have, as I said, the cause of death. You need to document the temperature, and a patient must not be hypothermic. The confounders must all be absent. This is the form that we use here in London Health Sciences Centre for brain death. They have to have no confounders. And we mention here some of the examples of confounders. They should not be in shock. They should not be hypothermic. They should not have a poisoning. They should not have muscle relaxation. They should not have any sedation or any residual sedation even on board. And so all of that should be absent. And then the examination, we should check off every single box here on this form. No response to nauseous stimulus, all these reflexes, and then document the blood gas at baseline, the blood gas after the apnea test. And if all of these, we can check off all these boxes, then they are diagnosed brain death, and the time of death is the time of the last blood gas after the apnea test, after the patient meets criteria for the apnea test. And so that is in Canada, that is how it works. Now, obviously, if the patient, for example, had a severe a motor vehicle crash, and you cannot do the pupils, for example, they lost their eye. And so you cannot tick off the pupils box, which means you cannot diagnose brain death based on clinical criteria. If you cannot tick off all these boxes, then you need to proceed to one of these ancillary tests. You need to document by testing, by imaging, that the patient is brain dead. And how do we document by imaging that the patient is brain dead? When you demonstrate that there's absolutely zero blood flow going to the brain. That is what you should demonstrate on imaging. If you go to do imaging, like radionuclide cerebral blood flow study, 4-vessel cerebral angiography, CT angiography, MRI angiography, xenon CT, all of these should give you, if you were to diagnose brain death, they should tell you that there's absolutely zero blood flow to the brain. Why is there zero blood flow to the brain? The ICP is extremely high, that there is no longer, that you cannot any longer deliver any blood to the brain. There's zero blood flow to the brain. That means the patient is brain dead. Now, obviously, you need to document the confounding factor that necessitated the ancillary testing. And sometimes we consider doing a transcranial Doppler, even though it's not one of the tests. But if you see blood flow in the middle cerebral artery, for example, on TCD, if you see blood flow there, then definitely the patient's not brain dead. Then there's no need to go ahead with these tests. The patient has blood flow to his brain. But TCDs rule out brain death, but they're not good to rule in. So if you do not see blood flow, you still need to go and proceed with one of these tests, so long as you're not able to meet clinical criteria. Now, what about in Saudi Arabia? In Saudi Arabia, there are practical references that have been published by the Saudi Center for Organ Transplantation, which in Saudi they call a SCOT. SCOT is Saudi Center for Organ Transplantation, and they have issued references, and the criteria in Saudi are even more strict. And so what they say is, You have to first do a first examination and see if the patient fits all the criteria for brain death, the same criteria that we went through. And then after the first examination, the patient should undergo a confirmatory test, one of these tests that we mentioned, to demonstrate no blood flow to the brain. And then 6 hours later, at a minimum, at least more than 6 hours later, another second examination should be performed, where you confirm that the patient still fits clinical criteria for brain death. And then step number 4, if all of that is still fitting criteria, you should do an apnea test. And if the patient has no respiratory efforts with the apnea test, then they are only then diagnosed as being brain death. And so the confirmatory tests that are recognized by the SCOT, by the Saudi Commission, are the 4-vessel angiography, EEG, TCD, CT angio, and radionucleotide angiography, any one of these. Only one of these tests should be done to diagnose brain death. Now, I have my reservations about this choice of tests because EEG and TCD, there's studies that have been done about this. I don't think EEG and TCD should be on that list because, as I said, TCD, it's a good rule out brain death, but it's not a good rule in, and there's studies that have shown that. And EEG, on the other hand, is also a study that you can get artifacts and think that the patient's not brain dead, but there actually are brain dead. And so EEG is not included in Canadian and US guidelines, and TCDs are not included as well. But they are included in the Saudi guidelines as confirmatory tests. And then after that, if it's an adult patient, another examination should be done 6 hours after the first one. And then if the examination is consistent with brain death, you proceed for the apnea test. And I just circle the EEG and the TCD. Now, the apnea test is very similar here, similar criteria. And basically, these are the 2 forms that they fill. The first exam is formed here, filled by 2 physicians, and then the second exam, at least 6 hours later for adults, 12 hours later for peds, and then 24 hours for neonates. And here, you fill out the forms and make sure that on both occasions, on both examinations, the 2 physicians agree that the patient actually fulfills criteria for brain death. Let's go back to religion. So when the spirit leaves the body. So when the spirit leaves the body, how do we know? Do we know that the spirit has left the body? We don't know. We really don't. As humans, we don't know. Nobody's really told us, come back from the dead to tell us that, the spirit has left the body. But there is a difference of opinion amongst scholars about brain death. And this is what I bring here. There's one of these consensus conferences that was in Mecca, led by Ibn Baz, rahimahullah. Their opinion, or their consensus opinion, was that brain death, موت الدماغ ليس بموت. You can still stop life support and everything, but they're saying the patient is only dead when the heart stops, according to their opinion. In this conference, they said brain death is a prelude to death, but the patient is not yet passed away. You may remove life support if the diagnosis of brain death is made by the consensus of 3 physicians, but the patient's only dead when the heart stops, according to their consensus opinion. The second conference, the one that was held in Jordan in 1986, this was also a consensus conference that was attended by a large body of scholars and physicians, where they actually said if brain death means that there's no blood flow to the brain, then brain death is actually death. Death certificates can be issued, organ procurement process may be started, and life support may be removed. So this is a matter of debate amongst the scholars. There's 2 documents from large bodies of scholars who have differed in their opinion about brain death when it comes to has the spirit left the body or not. And so one thing is for sure, though, if you're brain dead, the pen has been lifted. رفع القلم. If somebody's in the ICU and they're brain dead, there is nothing that they will do at this state that will bring them closer to Allah subhanahu wa ta'ala. And if the whole reason of our creation is for us to worship Allah subhanahu wa ta'ala and come close to Him, then in that state, when you're in the ICU, brain dead, dependent on machines, then there's nothing you can do from this point onwards that will bring you closer to Allah. The pen has been lifted. رُفِعَ الْقَلَمُ. That's it. What's been done has been done. Accountability for your actions stops once you have no consciousness. And what has been done in your life has been done. And from here on, you're just awaiting the inevitable. And so this is what I went through. It was a long presentation. Thank you very much for your time. I went through the rulings of seeking treatment and cure, the rulings of stopping life support, setting limits on interventions, DNAR, how to prepare for death, and the actual death itself. I thank you for your attention, and I'm open to your questions.
It is really a very interesting presentation, and you tackled from many views. I have two questions for you.
Yes.
First question, there is قاعدة شرعية الدفع أولى من الرفع.
Yes.
So it is there is a prerequisite that this does not contradict any legal or any religious benefit. So it have to be for something which is real. And if we try to apply here, so when we talk about a patient who's in advanced disease, so it is better not to go further by, for example, connecting him to ventilator and applying advanced life support, because we know by the end he's not going to make it. And this would be take the decision easier than already ventilating him, then deciding to withdraw the service in Western term after you already have ventilated him. I don't know what have you gone through this or not, or you have what you see? What is your opinion? The second question regarding the use of palliative care and palliative medication, something like midazolam, propofol, morphia, to alleviate pain and anxiety. In many instances, and this have been studied in some studies, the doses which is used to alleviate anxiety, alleviate pain, sometimes it is very near to the doses which can be used in assisting this. I don't know, what do you think about those two areas?
Yes. Jazakallah khair. Very, very interesting, very valid questions. And the first, regarding the first, you are absolutely right. There is a qaida shar'iyya, there is a rule in Islamic jurisprudence, and ad-daf' awla min al-raf', meaning that staying away and preventing is better and takes more priority than waiting for it to happen and then tackling it. And so what you mention here is extremely valid, and is actually, it makes our life as physicians when dealing with families, especially Muslim families in the West, it makes it easier when you actually know ahead of time and you've established a consensus by the expert physicians that instituting mechanical ventilation is not going to be of value, that putting patients on inotropes and pressors is not going to do anything other than prolong the inevitable and prolong the patient's suffering. And so preventing this from happening from the start and having family and everybody on the same page takes priority over just waiting to the last minute, the patient gets sick, take him to the ICU, put him on the ventilator, and start discussing withdrawal of life support. And so, as you said, refraining from the start is actually easier than taking away once it's already done. Now, they're already on a ventilator, taking it away afterwards, especially in a lot of Muslims' families, is very difficult. And so, but this has been something that has been looked at, and I've had extensive debates on this and discussions with scholars and scholars that have actually looked into this issue, scholars that have authored books on al-ahkam al-jarahat al-tabbiyya and on al-jinaya al-amd al-tabib. So I've had discussions with scholars that have actually had contributions to this field, and they are all in line with the consensus statement that was put forth by this conference, that if you have consensus of 3 expert physicians, then you can certainly definitely put limits. Now, it depends on the situation. It's very situation specific, Dr. Hisham, you obviously know this. You don't always know. You cannot always know beforehand that this will be a futile intervention. You don't always know that, but if you do, then yes, الدفع أولى من الرفع. This is a very valid ruling. And then the second question was about the opioids that you admit that you basically give for patients to relieve pain, and how this can maybe hasten death by a few minutes, maybe, right? And the doses are sometimes a little bit on the higher side. And from an ethical Western standpoint, this is a very well-known debate where they call it the double effect. And when you look it up in the literature, the double effect is exactly what you're describing, is that you are giving a medication with an intention of relieving pain. There's another effect of it, that it may slow down their breathing or whatever, but that's not your intention. Your intention, you're giving it for pain, and your end point when you're looking at the patient is not causing death. Your end point is that they're not grimacing and that they're looking comfortable, that they're not looking that they are in pain. And from a Western ethical standpoint, this is permissible because your primary intention is to relieve suffering and to avoid pain. And from an Islamic standpoint, I've also had this discussion with one of our local shuyukh here in Canada, and he said, yeah, your intention here is to prevent pain. Your intention, you have no other intention by giving this, and so this is completely permissible if you're titrating to comfort. That is what I have on it, and Jazakumullah khairan, very good questions.
Thanks very much for such comprehensive. I believe I never heard such a lecture on that topic similar to that, Amal, or even half of what you introduced today. So Jazakallah khair, it's really, really informative one. And the grades are, for me, at least after this lecture, are like crystal clear between different stages and the science and the religion behind. So again, Jazakallah khair. I have 2 questions here. I believe the first one we answered already from Ahmad Ali, but if you'd like to elaborate on that, you're absolutely welcome. So the question is, when patient is not for CPR and for end-of-life care pathway, what is the Islam point of view in that? What's the UK practice? And I may myself ask a question here because of maybe the condition of consensus of 3 expert physicians is not available all the time. So in certain situation, you will end up in the ICU with 1 or 2 trainees, and it's your own decision to end life or withdraw the life support from that patient, not withdrawing the care as you mentioned or highlighted. So in many situations, these 3 are not there. I think even in King Faisal, during the night time or in anywhere in big hospitals, During the nighttime, it's just one consultant plus a registrar and resident. So are we in a dilemma there if we don't have these 3 trusted doctors to make a decision? If this is not the hospital policy, should I still take that as a legal restriction or constraint to my decision? What would you, either in UK or wherever else? And if you like to take that question and highlight or elaborate on that.
Yeah, so in terms of if the patient is refusing CPR, is not for CPR, and is for end-of-life care pathway, as per the patient or their families and pre-expressed wishes, putting limits on life support is permissible. Putting limits on these interventions is permissible from an Islamic standpoint, and I hope that answers the question. In terms of the UK practice, I never practiced in the UK, but I can answer from an Islamic standpoint, according to the research that I presented, that it is permissible to put limits on life support and not basically do these things that the patient refuses to have done. The question that you ask about the dilemma. So the thing that I was actually quite pleased when I relocated to King Faisal in Saudi Arabia, that they have actually put together the hospital policy to go along exactly with the consensus statement published by the scholars. And so in order to make somebody DNAR, you need 3 licensed physicians to sign online in the power chart and the actual medical record that they've assessed the patient and they feel that the patient should be DNAR. And so who are these 3 physicians? Usually we try to get one of these 3 physicians to be the most responsible physician, their admitting physician, their admitting service, in addition to 2 licensed intensivists. They cannot be trainees. And so that is actually the hospital policy in King Faisal, which I was actually very pleased to see. And obviously we obviously tell families about this, and it's very important that we communicate. But the way it's presented, at least by the patient relations in the hospital and everything, this is a medical decision. You know, take the weight off your shoulders as family. This is a medical decision. Don't feel guilty about this. The physicians feel that this is the correct thing to do in his situation. And so this is so what happens if you're not in a place where you have 3 physicians? If you're like I am here,
which is most of us. So
yeah.
Trish, I'm working in UK, I work in UK, you're working in Canada, and you're still working in Canada actually. So when you're back to Canada
right now, yes,
yeah. Yes.
Oh.
So what do you feel legally or like religiously restrained by these 3 trusted doctors?
So typically what I'll do is, even though it's not documented, it's not really in hospital policy to have 3 physicians, but typically I will speak about it, even verbally, with others. I'll say this patient is, they've got a bad intracranial hemorrhage, they're in severe shock, they're on massive doses of pressors, and things are not looking good. I'm going to talk to family, recommend, stopping life support. Do you think would you agree? I said, yes, I would agree. And so verbally, I get that approval from the team that's rounding with me, and sometimes on the team, we have trainees who are actually licensed, who have completed initial training and doing further training. And a lot of times we have not a lot of times, we always have a second consultant. So we always, at least in Canada, we have a day team and a night team, and we round together on handover. And so these items are usually discussed between the 2 consultants and the team. And I mean, to be completely frank, do I feel often restricted by this consensus statement that we must have 3 physicians? A lot of times it's clear. A lot of times it's not. It doesn't need, you know, the three physicians, especially if you've discussed it with another consultant and we're all on the same page, the team's on the same page. Yeah, and it's a lot of times it's very it's self-fulfilling. And I don't feel guilt that I don't have a third licensed physician a lot of times, and that's a personal sort of disclosure that I make. But if you want to go by the book, the consensus statement says you need 3 physicians.
Yeah, it may be the other way around. Like as you mentioned, there is always a second opinion, but it's a second, not a third opinion. What I usually do in that situation is I share my idea with the team and see if there is any like strong conflict with anyone to say, but there is and this and that. So if there is no conflict, I feel that every trusted doctor, even licensed or not licensed, that's not the point. It makes a lot of sense as a background and then a second opinion. So it will be 2 consultants plus the background from all people around, all in agreement with that. And what really pleased me in what you had brought on our table today, it does not say 3 Muslim. Otherwise, we'll be in a big trouble here, because not every place in the whole world has these Muslims, and Muslims are working in a lot of non-Muslim countries, and it's not talking about Muslims' life only, it's about all the patients' lives. So I'm very pleased that it says 3 trusted doctors. It's not inclusive to only Muslims, or it's not exclusive for Muslims only. You agree with that?
Yes, yes.
3 trusted to a second consultant plus the background of everyone else in the team agrees with that. And sometimes if it's in the daylight, I get the agreement of the treating consultant plus a second opinion from ICU colleague, consultant or intensivist colleague who is experienced enough, and this will be the 3. Usually there is, again, there's no debate about it or there's no conflict. So let's go to the second question. Thank you very much, Jazakallah khair.
Can I just add a bit here? I would like to ask Ahmed.
Please go ahead.
We have a similar policy in Ministry of Health, but there is one paragraph saying that you need to inform the family about the decision. You don't need to take their opinion. It's a medical opinion, but you need to tell the family. Many times, the family oppose the decision, which cause a bit of conflict and make it not easy to implement a DNR decision. I'm not sure, what do you have in King Faisal? Do you have such thing? What do you do regarding involving the family in this decision?
Yes, it's a very, very, very valid question. And it's a common encounter that you actually see. Yes, you have to inform them. And a lot of times they will say, why? Well, he's already dead. What do you have to lose? Can't you just do CPR? Why not? And so I try to walk them through it. I try to tell them that what we're doing has a religious standing. And this is and there's actually some of the hospitals in Saudi Arabia have the fatwa printed for families to read of Majma' Fiqh al-Islami. And I try to explain to them that this is torture. Because obviously what you want to do is basically torturing him in his last moments. If you are interested in breaking his ribs in his final moments, it's not going to change his outcomes. And I try to explain to them that this is, at the end of the day, if you came to me for miracles, then you came to the wrong person. I'm not in the business of miracles. You came to me for medicine, not miracles, right? If Allah subhanahu wa ta'ala decreed for this person to live, regardless of whatever I do here, he may not even come to the hospital, Allah subhanahu wa ta'ala will cure him. But if you're talking to me, you come to me for medical opinion, not for miracle opinions, right? But from a medical standpoint, given al-mu'tiyat al-tibbiyya, given the medical, what we're given right now in his situation, nobody in his situation, from a medical standpoint, has survived. And so this is what we have, and I try to walk them through it. Now, obviously, what we have in King Faisal, if there's still a conflict and they're still not in agreement, we call patient relations. And we go through a conflict resolution process with patient relations. And a lot of times patient relations actually are quite helpful in terms of calming down the family, telling them that the team here is doing everything they can. They think that this intervention is not necessary, but it's a medical decision, and they've exhausted every effort to treat your loved one. They're not falling back. They're not, and I find a lot of times that they are helpful, actually, patient relations in King Faisal. But I agree, a lot of times we are faced with difficulties. I totally agree. And I think Dr. Hisham, let me say real quick, and I think, Wallahu A'lam, a large part of it is lack of knowledge. I feel like, Wallahu A'lam, that a large part of it is that a lot of Muslims don't know or feel like it's obligatory to do everything to the very last minute. That's what a lot of Muslims' beliefs are. And they will come to you saying, no, keep doing everything. And I think it's partly because we have never been educated about the rulings on this. These what the scholars have to say about it and all this, and what the companions even have done. We have examples in our companions of the Prophet ﷺ where they were faced with terminal illness and they were asked, should we bring you a physician? It's narrated that Abu Bakr as-Siddiq radiallahu anhu in his final days was offered physician medical treatment, and he said, no, I'm submitting to my body and my will to Allah subhanahu wa ta'ala, and I am content with whatever Allah will bring me. And so when we have examples of actual Sahaba that have in their final days said, I don't want treatment, and we have evidence from the Sunnah, and we have the scholars telling us that stopping or putting limits on treatment is permissible. From a Shari'i standpoint, it is permissible. People don't know this. And that's I feel is where the problem stems, is that they want everything done. And obviously the other part of it is the feeling of guilt. This is my loved one, and I want everything done for him as I would want everything done for me. And at the end of the day, we are physicians. We are only means. We are physical means, and the lives are with Allah subhanahu wa ta'ala. We can only do what Allah subhanahu wa ta'ala has taught us to do. Allah.
I agree with you in many occasions. It's just a normal human reaction from the family for their beloved father or mother. However, I remember have been a long time back when I was working in Medina Munawwara. And we had a patient and we told the son it's for DNR and we don't want to torture him, break his ribs, blah, 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 blah. And he agreed. Sometimes the policy needed him to sign. So the son signed. Then after a couple of hours, he came back and said, I want to withdraw my signature. So we asked him what happened. Then he said, no, I want you to break his ribs, because this will be takfir zunub before he pass away. We were a bit dazzled what to tell him.
That's another misunderstanding. Okay, so I thought your talk and questions answered everything until I had seen a question from Ahmed Abdul Hafiz. So Jazakallah khair, Ahmed. So from a religious point of view, what is the consensus if the medical assessment indicating a vegetative state? And I think most of us know what is a vegetative state. And he's not dying, but obviously not improving. What is the opinion about withdrawal of life support? So if this patient, my understanding as a vegetative state, he could not be breathing on his own, and like similar conditions. So if you withdraw the ventilator, it's kind of actively killing him, and while he's not a brain dead. So if you elaborate on that, Ahmed, and Jazakallah khair. So just before you go with that, Dr. Islam Abdulaziz is saying, can this recording of this presentation be available to us? Yes, I will do the video editing, inshallah, to make it the best and most time efficient, and that will be available in 1 or 2 weeks on Saving Lives Academy. You had seen me like putting nothing on the academy for like almost a year, because there was nothing obviously adding to the big amount of lectures coming every day. So enjoy. I don't want to interrupt now and then and repeating what is highlighted before, but whenever there is a chance of improvement, you'll find me coming and saying this is a new lecture adding to Saving Lives Academy. So whenever there is a value, I feel it's added, so you will find me coming and adding that immediately. So it will be available in Saving Lives Academy within 1 or 2 weeks, depends on how fast I can do the video edit. And I cannot send that by email to every one of you. So please keep an eye on Saving Lives Academy, and it will be coming as soon as I can, inshallah. So Ahmad, you can answer the question, please, and thank you.
So patient who is vegetative and at the same time he's not in any, he's not on inotropes, he's not dying, but he has permanent brain damage and is completely dependent on care. Then the ruling on stopping life support is that it is permissible in this regard. And I reference here the two fatwas that and these are the sources. It says if resuscitating the heart and lungs is futile and not suitable for a certain condition, as per the opinion of 3 expert trustworthy physicians, there is no need for the use of resuscitation machines, and there is no need to turn to the opinion of the patient's family in this regard, as this matter is not within their area of specialty. So this is from an Islamic ruling standpoint, stopping life support is allowed in this situation. From a practice medical standpoint, it really does depend on the practices and policies that you have in place in your hospital, and whether you are able to do this in this fashion, and what are the prerequisites for you to actually stop life support? Should family all be consenting? Should we have consensus from more than one physician? All of that is a matter of the practices and policies that you have. I'm just here to show you that the ruling that it is allowed from an Islamic standpoint, but you can turn to your hospital practices and policies to see how you can implement this in a way that is compliant.
If you allow me just to comment about this area. As Ahmed mentioned in his lecture, there is a very clear prerequisite for brain death, that you need to know why this patient sustained irreversible brain damage and is not in sedation, is not in severe metabolic. This is very important. And the second issue is it needs to be done by 2 senior persons. You cannot dedicate it for a trainee. And this what have caused a lot of misunderstanding with the lay people. And they will tell you, we have heard about a patient who was labeled as a brain death, then he wake up later. Some of the instances were actually because we as a physician, we are not sticking to the rules. We are not sticking that we should implement the prerequisites and how the examination need to be done and by whom. But Ahmed, he mentioned this very clearly in his lecture. And I think this is one of the causes which cause a lot of confusion between the public. I remember a long time back we have in the media in Egypt and here even in Saudi Arabia about, is there a concept of brain death? A lot of people were doubting there is no brain death. One of the causes of this was the people, the physicians, they are not taking it serious enough. This is a very serious, because when you do a brain examination, you end up that this patient is dead. And yes, there is a bit two views, as you mentioned. Shar'an, is he dead? So there is inheritance rules, blah 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 blah. Is it from the apprentice or after complete cessation of cardiorespiratory function? It have to be very serious and have to be taken with complete respect to the rules.
Yes, Jazakallah khair. Agreed, 100%.
So if any of our attendees here, Jazakumullah khair for your patience with us until now. It's been 90 minutes so far. Is it 90 minutes, I believe? Yes. So if you have any questions, please raise your hands. So just from regulatory point of view, to avoid unintentional mic opening and noise in the background, I put all on mute. So please raise hands and I'll give you the mic if you have any questions uncovered so far, or we'll take this meeting to an end. And I really will miss Dr. Hisham and Dr. Ahmed until the next meeting. So obviously, don't have any questions here. So stepping back, Dr. Hisham, the floor is yours to conclude the meeting with Dr. Ahmed. Thank you. Jazakum Allah khairan, both of you.
جزاكم الله خير. يعني really we enjoyed. Many thanks Walid for arranging for this meeting. Ahmed, يعني you present a lot of data from all scientific, medical, شرعا. جزاك الله خير. جزاكم الله خير. شكرا جزيلا.
Thank you so much. Thank you. Thank you for having me. It was a pleasure. يعطيكم العافية وجزاكم الله خير.